worries.
The recording has started, and all right. Can you confirm you can see the first slide?
Yes, we can see it. Thank you.
Perfect.
All right, so hi everyone. I'm Lindsay Sizemore, the Viral Hepatitis Program Director for the Tennessee Department of Health. And again, I'm going to be your facilitator for most of these sessions, if not all. So today's agenda will include, Heather, can you actually go on to the next slide? So today's agenda will include introductions and announcements, a quick recap from the case presentation from our last call, because I know that we ran out of time and there was some really good discussion that happened after. A didactic presentation by myself and Laura Price that will highlight linkage to care and hepatitis C resources for children, and a pediatric case presentation with time for Q&A and closing remarks. Now, Heather, can you go back one slide? Thank you. So before we get started, I'd like everyone to take a second to just introduce themselves in the chat. So as promised last time, I'm not going to have everyone come off mute and introduce themselves again. We did that once, but I would like to know who's on the call. So if you could do your name, your role, your organization, and if this is your first echo session with us, we would really appreciate that information as well. So I'll give you all just a second to do that. And then I will have another ask of you. Okay, seeing some. Okay, so for those of you who are done with that, Heather, can you go to the next slide? So again, a few quick reminders I want to highlight that I will cover every time. So this is the most important announcement, so please listen carefully. If everyone, including our subject matter experts and TDH team, can take just a minute to go to this website here, you can also scan the QR code and fill out this sign-in sheet. This is how we have proof for our accrediting body that you were here. If you don't fill this out, you will not be eligible for CE, but also even if you don't want CE, we need you to fill this out. So if everyone could just take a minute and do that and then give me a thumbs up when you're done, I would really appreciate it. And the link is also in the chat if you are having any issues accessing it. So we have at least one new person. That's great. Welcome. Tell your friends. Invite everybody. We really want to see this grow. All right, seeing just a few thumbs up, but I'm going to give it just another minute. Okay, so while everyone's kind of finishing that up, Dr. Chastain, would you like to give your evaluation announcement?
Sure, I'll just briefly state that I am the principal investigator for the Southeast AIDS Education and Training Center. That means that I and my team at Vanderbilt University Medical Center can provide technical assistance, education, and other support services to you and to your team or your institution, wherever you are, if it pertains to HIV care and or comorbid conditions, which include viral hepatitis and others. For us to be able to do what we do for free for a variety of partners, we basically just have to track who we touch through educational programming, other activities. And so if you are willing, I would ask you, while we're going through introductions of things, is to complete one additional log on. Clove Tipton has just dropped that registration link into the chat box. Thank you so much for the time.
Thanks, Dr. Chastain, and thanks everyone for doing all the things that we're asking you to do at the very beginning of our call, but it is really important. Okay, next slide, Heather. Okay, so just a few quick reminders. So please turn on your video and mute yourself unless you are speaking. And please come off mute to ask any questions that you have. We are not scary. We are really trying to promote collaboration and discussion, and we can't do that if no one says anything. So please do that for us. Anastasia, has anyone joined by phone only? Nope. Great. Next slide. So please never discuss PHI and please treat everyone with respect. And so with that, I'm going to actually turn it over to Shamia to recap our case presentation from the last session. So Mia, can you take it away?
Yes, hello everyone. So as Lindsay mentioned, we're just recapping the postpartum case presentation from our last session as we kind of wrapped it up there in the last few minutes, and there were some great questions. So it was regarding a 27-year-old Black non-Hispanic female with Medicaid insurance. The last live birth was in 2022. This person has a history of hypertension, anxiety, and migraines. They also reported using stimulants and marijuana. They do take nefafetapine daily and hydroxyzine 4 times a day as needed for anxiety. They were negative for hepatitis A and hepatitis B, as well as HIV. Their quantitative HCV was a little over 4 million, genotype 1A, and no indications of cirrhosis. And this is a treatment naive client. So next slide. As we were wrapping up last session and kind of went over some of the recommendations, it was noted that this person is in fact treatment naive and eligible for simplified treatment guidance, not having cirrhosis. And so some of our SMEs went over those recommendations, and I've just recapped them here, and those options to give perhaps Mavorite or Epclusa. And then we started talking more about possible drug interactions or what we would need to consider and some other things. So we'll start with the last question that was asked during the last session, which was, is there any correlation between high viral loads or high quantitative hepatitis C RNA values and vertical transmission? So where hepatitis C has passed from the mother to infant. And so anyone that was on the last session, feel free and caught that, feel free to unmute yourself and share that information with us, and we can start talking about that and then go from there.
So I was not in the last session, but I can tell you that there is significantly association with vertical transmission if the mom has actually high replication of the virus. So that's something that even increases the risk for that baby to actually has Hep C. And I think it's one of those interesting cases in which, until I know so far, FDA has approved it for children, not so much for pregnant women. But then that's a kid that you would have to follow up really closely because he's at increased risk for vertical transmission.
So that is what was mentioned last time too. And so really interesting. And as we're talking about thinking of the infant being tested and obviously getting mom treated postpartum, there are some questions related to that. So one of them being, and we talked a little bit about this in last session, about breastfeeding and taking medications, and if there would be concerns there. But then also another question that came up is, as a mother is breastfeeding, are there any considerations she needs to take in terms of whether or not that could potentially transmit hepatitis C? Anyone have any initial thoughts about that? And again, feel free to take yourself off mute, and there's no wrong answers, just discussion points.
I saw Dr. Chastain raising his hand.
Oh, okay, go ahead.
I didn't want to interrupt for other folks. I was going to just make a follow-up comment from Dr. Alfaro's mention that she mentioned that currently it is not recommended for treatment during pregnancy, but I think this is really important how we frame. The current guidance has moved from it's not recommended to treat women during pregnancy to treatment during pregnancy may be discussed between a provider and patient regarding the risks and benefits of treatment. And those are subtly different things, right? We've moved from a place several years ago where it was really kind of a recommendation against treatment because of lack of safety data. And while we don't have robust data at this point, we do have case reports, case series, and anecdotal experience where women who have become pregnant during the course of treatment or were treated intentionally after discussion with the treatment provider regarding the risks and benefits. And all of the data that we do have available to us is that treatment for hepatitis C is safe for mom and baby. That's different than saying that on the label of the medication that it is deemed safe. And it's also different than the guidelines recommending to treat women who are pregnant, which I hope is a place that we will get to in the future, where we have sufficient data that recommendation for pregnant women is not just a consideration, but actually is a recommendation. And actually we get to the point that treating pregnant women is a priority, because I think those are subtle differences that I think we're going to require additional data and experience to guide us into that place. But I can imagine a scenario in not too distant future that actually pregnant women are some of the most important people to actually start therapy to eliminate the risk of mother-to-child transmission. At this point, it is a provider and patient imperative to discuss that. And admittedly, in my own practice, that's changed over the last couple of years, where I've moved away from saying that we don't know about safety in women who are pregnant or persons who are pregnant. And I've moved that conversation to is that we have very limited data and very limited information, and sharing that data and information with people who are pregnant to help them individualize what they think is best for them and their pregnancy.
Now, just to follow up, I think, yes, you have a point in saying if we are able to treat pregnant women, we're probably significantly going to decrease infection in children. Most of the infections that we see in children are actually because of vertical transmission. So that definitely will be a key goal if we're able to treat pregnant women before they have that baby. As for me, I know you were talking about breastfeeding. And so currently the CDC guidelines, they have no contraindication for that mom to breastfeed. They are recommending that they should actually breastfeed, but if there is anything like, for example, a crack areola or the surrounding areas, or they're bleeding, then they would recommend not using that breast to breastfeed while they heal. But so far, there's no contraindications on that, as it's usually not associated with transmission through breast milk.
So thank you, Dr. Chastain and Dr. Alfaro-Cruz. Both of those are really encouraging points. And kind of circling back to possibly discussing some of the whether or not there's potential for drug-to-drug interactions with this patient taking the nefenfetapine and hydroxyzine. Should that be something that is considered, or any thoughts on that when we're looking at the potential recommendations of Mavyret and Epclusa?
Yeah, no drug interactions between those two agents. We'll cover that in a later section, but between those two agents, I'm not concerned about any drug interactions between those two. All options for hepatitis C treatment are on the table.
So more encouraging news for this client. And I believe that this person was recently seen and actually started on one of these medications, if I recall correctly. So encouraging. Anyone else have something that they wanted to add, or additional questions or comments? And again, please feel free to take yourself off mute and spark a conversation. Or any clarifying questions even.
Yeah, I'll just say that when I talk to women that have this concern when we're navigating, so the recommendation is they can pump and discard that milk, and they could bottle feed, give formula during that time, and then resume breastfeeding when the nipples healed.
So yeah, that's a good point. Doesn't have to stop breastfeeding. It can just be short while they're healing. So yes, definitely something that could be important to a lot of mothers. So good thing to mention. Any other clarifying points or questions?
I just wondered whether both of these are TennCare approved, or whether that depends on the MCO. Does anyone know?
Both Mavyret and Epclusa are on formulary for TennCare. Harvoni is also on formulary for TennCare. She has been approved for Mavyret, and we will probably reach out to her soon to get her accounts with them started.
All right. Well, if no other clarifying questions or comments, Lindsay, do you want to take us from here?
Yes, thank you so much. Okay, can everybody hear me okay? Great. All right, so as mentioned, Laura Price and I are going to present about linkage to care and hepatitis C virus resources for children. So I'm going to start this presentation by giving you a background of why we started conducting perinatal hepatitis C navigation, and then Laura will get into the specifics of our linkage to care and provider education efforts. So there was a study published in 2017 that specifically looked at women who had hepatitis C during their pregnancy, and that from 2009 to 2014, the prevalence of maternal hepatitis C increased 163% in Tennessee and disproportionately impacted rural and white populations. In fact, this particular study also found that women living in a rural county were determined to be 3 times more likely to have had maternal hepatitis C. There was also a study published in 2019 that specifically looked at women and found that from 2000 to 2015, rates of hepatitis C infection increased 148% among women with opioid use disorder. And during the same time period, the national rate of hepatitis C among women giving birth increased more than 400%. Also concerning is that in 2020, perinatal hepatitis C exposures were reported in 88 counties in Tennessee. So again, I'm talking about exposures and not necessarily infections. But some counties did demonstrate that 5% to 8% of all live births in those counties in 2020 were perinatally exposed to hepatitis C. And also of the 1,126 infants perinatally exposed to hep C, the majority, so about 91%, had no clear evidence of appropriate testing reported to TDH, thus leaving them a suspect case. Of note, though, appropriate testing of infants remains a significant issue. However, given that currently hepatitis C antibody negative results are not reportable in Tennessee, it's possible that these infants are being tested and testing antibody negative, which is ideal. And our team is currently working to try to tease that out. Is it a testing issue? Is it a reporting issue? What is going on? So more to come on that through these echoes. So in response to these studies and our surveillance data, in August of 2019, we established the perinatal hepatitis C coordinator position, which is Laura Price, to address barriers to accessing hepatitis C treatment for postpartum individuals, assisting postpartum individuals living with hep C in accessing hepatitis C care and treatment services, as well as other supportive services, because again, it is super important to get these postpartum individuals linked to hep C treatment, of course, but also we have to inquire about other needs that they have. So, some things that we've heard is, I'm hungry, right? Like someone cannot possibly talk to you about hepatitis C treatment if they're hungry, and those needs are not being met. So it is trying to link individuals to hep C treatment, but also keeping in mind those supportive services, but most importantly, building that relationship so they know there is someone here who can navigate you, who you can talk to, who you can contact at any time. And it's not uncommon for people to follow up with us later. We also wanted this position to liaise with community organizations and cultivate program awareness of harm reduction activities, also to talk to providers, just to educate about all the things, right? But especially the updated testing recommendations for hepatitis C and things of that nature. And also to encourage appropriate hep C testing for perinatally exposed infants. I want to mention that when we started this project in 2019 with Laura, her catchment area was and still is Knoxville and the 15 surrounding counties that make up the East Tennessee Public Health Region, which I'm sure you understand why given the map that we showed of the exposures. But it's exciting because as of the end of last year, we have actually expanded this to be statewide. And so this is a statewide resource that we provide. And that's what it looks like. And so again, we got it off the ground July 1st of 2022, but it was really, really, I would say, a well-oiled machine as of the end of last year. And so Laura does provide oversight to these navigators. And so again, Laura is the perinatal hepatitis C coordinator, and these are our perinatal hepatitis C navigators. So with that, I'm going to turn it over to Laura to discuss our linkage to care efforts.
So hello, everyone. It's nice to be on the call today. So yeah, as Lindsay said, I'm Laura, and I am the perinatal hepatitis C coordinator, and I work very closely with hepatitis C navigators across the state. So navigation to hepatitis C treatment and harm reduction services is our overarching goal to offer cure to all people living with hepatitis C. What we're seeing is that most pediatric providers are ordering hepatitis C antibody collection at or greater than 18 months of age due to clearance of transient maternal antibodies. Tennessee Department of Health, though, is encouraging CDC current draft recommendation, which encourages earlier RNA testing. So we want to be sure to really emphasize that we do not want any missed opportunities with this vulnerable population. When they show up for a visit, we need to take advantage of every opportunity given us. So our conversation about perinatal hepatitis exposure and testing must be with the birth mother due to HIPAA. So unless a child is in confirmed DCS custody. So we utilize the TENNIS database or the immunizations registry for guardian determination because it provides the most current or up-to-date information regarding the guardian, the PCP, and demographic information for that birth mom. And so we will reach out to mom if it's documented, she's documented as the guardian, or it could be another name, but as long as they share demographic information, we're going to go with that initially to see if we can make initial contact. We're going to reach out to DCS nurse consultants if someone other than the birth mother is listed with demographic information that does not match. If DCS is actually listed as the guardian, or the current documented address is not a residential address. Now that we're doing this for a bit, we can often just recognize the DCS address in TENNIS right off the bat. Even if they don't mention DCS, you see the address and you know. So to infant follow-up, so children perinatally exposed to hepatitis C are followed until the child is either appropriately tested or is lost to follow-up. So the time points that we do the follow-up are at 2 months, 24 months, 2 months, 12 months, 24 months, and 36 months, because we wanted to have this coincide with the well child visit, get these moms in with the children, so we don't want to add additional visits. So appropriately tested is considered as a HCV antibody collected at or after 18 months of age, or the hepatitis C RNA collected at or after 2 months of age. The children are considered lost to follow-up if there's been an adoption, they've moved out of state, they have not been appropriately tested by 36 months of age, or if unfortunately there's been a death. So, provider education efforts. So in order to know where to focus interventions, we rely heavily on surveillance data. Providers must report cases of acute or perinatal hepatitis C to the Tennessee Department of Health within 1 week of identification. All laboratories must report all positive hepatitis C antibody tests and provide positive and negative hepatitis C RNA confirmatory assays. We also educate on the hepatitis C testing recommendations. I know most of you are aware of these, but we wanted to include them here and discuss briefly in case there's some who are not. And so you can use these slides for a reference. As mentioned earlier, in April 2020, the CDC released updated hepatitis C testing recommendations, which includes one-time testing for all adults, testing pregnant women during each pregnancy except in settings where the prevalence is less than 0.1%. I would like to note that CDC acknowledges that no state has a prevalence of less than 0.1% in terms of adult testing. The U.S. Preventive Task Force recommends testing for hepatitis C virus in adults aged 18 to 79 years, which is a grade B recommendation. The AASLD and the IDSA recommend one-time routine opt-out hepatitis C testing for all individuals 18 years or older, as well as part of routine care during each pregnancy. They also recommend hepatitis C testing for children perinatally exposed and siblings of children with vertically acquired chronic hepatitis C infection if born from the same mother. And ACOG now recommends screening for hepatitis C virus for all pregnant individuals during each pregnancy. And the Society for Maternal Fetal Medicine endorsed this practice advisory. So here's just a few of the educational materials that we have developed. We adapted this hepatitis C in pregnancy and women brochure from our friends in Indiana. It is available in English, Spanish, and Arabic on our website, or we have hard copies that we can share with you if you'd like. We've also developed a hepatitis C testing recommendation one-pager for children. The perinatal hepatitis C navigators mailed this to the guardians and encouraged them to take it to the child's pediatrician. This one-pager outlines testing recommendations for children born to a person with hepatitis C virus, some frequently asked questions as it relates to infant hepatitis C testing, and information on vertical transmission of hepatitis C and reporting requirements to the Tennessee Department of Health. This is also available on our website. So Medicaid covers almost half of all births in the US, and women on Medicaid are 83% more likely than women who have private health insurance to have chronic health conditions that can put them at higher risk for poor maternal outcomes. As of April 1, 2022, TennCare increased postpartum coverage from 60 days to 12 months following the end of pregnancy and offers a dental benefits package to pregnant and postpartum women. This provides an opportunity to cure postpartum that was not feasible during the 60 days previously covered, and some maternal fetal medicine high-risk OB providers may want to incorporate hepatitis C treatment into their practices to prevent disruptions in care that can happen with transfers and referrals. Now back to Lindsay to talk about literature.
Thanks, Laura. So just like our last session, I want to make you aware of a recent study that relates to the information we've covered today. So I learned on a recent CDC webinar that there was a study published in August of 2022 that determined that the rates of vertical transmission of hepatitis C are actually higher than previously thought. So previously it was estimated to be about 6% with each pregnancy, but it's now estimated to be about 7% with each pregnancy. And it's also estimated that for mothers who have both hepatitis C and HIV, the vertical transmission risk of hepatitis C is about 12%. The study also found that after accounting for spontaneous clearance, rates of hepatitis C infection at age 5 were about 2.4%. And most transmission appears to occur late in gestation, with some occurring early in gestation and some less occurring during delivery. So this is linked here if you want to check it out, but anytime we identify any kind of relevant literature, we want to share that with this group. Okay, so as a reminder, you can always email us with questions at echo.tn@tn.gov, but we're also happy to answer any questions that you have now about the didactic presentation before we jump into the case presentation for today. Any questions? I know that was a lot.
Lindsay, I wonder if you can, for our practitioner or providers that are listening to us, something that a very common question that I get from our local primary care providers is, right now that we're thinking about testing infants sooner, is this something that is going to be covered by teen care if we start, testing at 2 months of age, or depending on what time? So that's a very common question that I do get asked about who's gonna foot the bill for that changes in testing.
That's definitely a fair question, and one that I had as well, because best practice for Hep C testing in general is reflex testing, right? Which is the antibody. If it's positive, you do the RNA on the same sample. And so I thought, is TennCare going to pay for the RNA testing at 2 months, right? Because we all certainly see the value. We don't want to have loss to follow-up. We want to empower mom in that postpartum period, et cetera. So I did ask my TennCare contact and was told that they will cover the RNA testing at 2 months. So you do not have to wait until 18 months to do the antibody testing.
And now, usually, in that case, we usually tend to get genotype. And I think that was something that we were discussing on our first echo, where kids usually will get the genotype because it's covered by TennCare. That compared to adults, where it can be a little bit more difficult pending insurance. Is that something that, we hope that it's still going to keep happening, where we'll get the genotype at age 3, that way we can continue treatment based on that?
So that one, I am not actually sure. Dr. Talley, do you want to add to that?
I am not aware of that. We can certainly look into it and follow up at the next echo session as well. But I also just wanted to point out, and Dr. Alfaro, whether you've seen this in primary care folks who've reached out to you, that it's not necessary to repeat the testing again and again and again. A positive at 2 months would suffice until age 3 when a treatment decision is made.
Yeah, I think that's kind of important to say, because, I think we have changed the way we're screening now or testing our children. So that's something that definitely have that message that we don't need to repeat. We don't need to do, we're doing it 2 months, we're doing 9 months, we're doing 18 months. So I think sending that message clear that once you test, then we'll reassess at the time they turn 3. It's going to be very important to facilitate care.
Thank you. Circling back to the genotype question, specifically in children, Dr. Chastain, Dr. Allen, do you happen to have any insights there?
No insight for me. Yeah, I'd have to look it up. Probably have to call somebody. I'm not sure off the top of my head.
Yeah, I wouldn't, I think Dr. Alfaro Cruz will, I think, speak to this as well. I think in the context when we struggle with systems in adult and pediatrics as much as anything. Like, we know medications that are available. We know that they're effective. Approval and processes are often inhibitors as far as navigating these challenges. I think from a volume standpoint, in adult patients, we have such a greater volume of patients we have to traverse and move forward onto treatment that we have pretty well developed pathways about how to get by without all of the pieces of data that would be a perfect scenario. If we're missing data, if we're missing genotypes or other things, we have kind of established pathways as workarounds because we have enough volume of patients that we have to move on to treatment to navigate those barriers. I don't personally treat pediatric or adolescent patients, but I know that just from a volume standpoint, a lot of our biggest challenges in this population is to capture them, screen them, to engage them in care. Only a subset ultimately will end up being treated in ECHO, which means that we end up with a smaller subset. We have to encounter these questions about what additional therapies. The other piece of this for me comes out, and it's just all about administration. I have some experience with consulting with other groups and having kids as far as taking the medications. The formulations that are available for children, and that comes a lot to do with as far as what can be administered and how to administer it. And so for me, like, genotype is often clinically, it's the least important thing to me in the era of pangenotypic regimens. It's all about, can I get the med? Can my patient take the medicine? And often, as far as getting the medicine, are these workarounds. And I think that, no, honestly, this is partly the benefit of these type of communities of connecting people, so that as we have people in the community who are engaging in this, is that if you're venturing out in the space, if for some reason I have to treat a adolescent who has challenges with dysphagia and swallowing, this is going to be fantastic because I'm going to talk to Dr. Alvaro Cruz, who's got more experience with potentially that. And so I think actually it's a long-winded way of saying that I think that's part of the goal of this community is that even some of our subject matter experts, we're going to have limited experience in very specific spaces, but building a community, that means this should be an open-ended place for anyone to bring their cases, to bring their questions, and to navigate that. It's not just about selection of therapy. It also might be about navigating care in your community.
And I can tell you something, the fact that the companies have thought about that, right? Ingesting the medication and creating oral pellets. And I think Clark will kind of support me there. It does make a big difference in having that kid and having that child adhere to therapy. I've had adolescents who, as you said, they cannot swallow pills. We kind of even have provided like an education on how to swallow pills, and they're still not able to. So definitely the pellets presentation has helping us significantly in how to actually treat that. And kind of, as you said, we tend to forget about the genotype when the goal is actually to treat that patient and get that medication on board.
Thank you both so much for that. And see you all, any question will be entertained. We're going to have a robust discussion. It's not scary. So thank you. That was really insightful. I do see one question in the chat. So is there a significant cost difference in hepatitis C antibody and hepatitis C antibody reflex to RNA? So I can answer this from what I know. And if anyone understands it differently, please let me know. So antibody is cheaper, which is why we start with that usually, because you want to kind of weed out those who are going to test antibody negative, and then you don't need to go on to the RNA. So the RNA is more expensive, but we're not talking, you know, $5 versus $500. It's more like $10 for one, $40 for the other. So there is a cost difference, but I wouldn't necessarily call it significant. Others' thoughts?
And I think, Lindsay, one thing you kind of pointed to is I think it's really important to highlight when you do reflex testing, the RNA test isn't paid for or required if that antibody test is negative. So you're only utilizing it when you need it, and you're eliminating asking your client or patient to come back in for an additional visit, which again could, you know, cause there to be office visit costs, potential other costs. So when you're really thinking about, is this cost effective, it has been found to be a good way to do it and also eliminate some of the burden on the patient as well.
And it's interesting that you said that, Mia, because the conversations that CDC is having right now in terms of their testing recommendations that are going to come out this year for children, they're not necessarily looking at that reflex testing, right? They're more focused on that RNA at 2 months because they don't want that family to be lost to follow up. And we are so behind that and so excited for that to come out. Other questions, comments, thoughts before we move on?
I see another question in the chat from Jenna. Can the pills be crushed and administered in pureed food such as applesauce? Would there be possible indications for that? I'm assuming in children or those that wouldn't be able to swallow.
So we've done it a couple of times in patients. I can think of a patient specifically that had only food by a G-tube. So we did allow him to, it's not on the ISMP do not crush list. So we used Harvoni and had him go through a course of Harvoni for 12 weeks, and he crushed it and put it down a G-tube, and he was successful. That might be anecdotal evidence. I don't know of any other people. I haven't looked for case reports, but we were successful in the one patient we did try who wasn't capable of even swallowing the pills, and he did crush it and put it down a G-tube.
Well, I was just thinking, you know,
So I will say that I can speak to this briefly because we actually did a case series of crushing and splitting direct acting antiviral tablets. There was a collaboration between some of the people I work with at Vanderbilt, as well as at Temple University and University of South Carolina. And we collected a small number, but still over 10 different cases where we had either split or crushed glycacropyridosphere, sofosbuvir velpatasvir, or ladipsavir sofosbuvir. All patients did well. All patients are here without any adverse issues or effects. I think it's not necessarily ideal, but I think it's also interesting that pellets are great, but actually in adult patients, especially if you have adult size patients, the amount that you have of pellets that you have to use is actually fairly substantial. And so actually getting the pellets and crushing the pellets further is not the most efficacious or easy way to navigate it. It's much easier to start with the traditionally packaged size of tablets for adults or adult size patients. So again, I would say, Clark, limited evidence. I can back that because it's definitely just a series of anecdotes. But I think generally speaking, if you talk to anybody who does a large volume of hepatitis care, I think we've all done this, and we've actually done it multiple times and collected some of that information. I dropped that link into the chat box for folks who are interested as far as that case series.
Thank you both. Dr. Allen, I see your comment about the reference lab AEL, so I would like to connect with you offline because I have some ideas about that. For those of you who don't know, Dr. Debbie Allen is one of our health department Hep C treating champions. And then there was another comment. I've had multiple cases where pills had to be crushed. They were all successful. Great. Okay, just to make sure we